I'm Nick Riker. I'm currently working for MSIF, but a bit about where my perspective on advocacy comes from. I've worked for patient organisations since 2007, on MS since 2012, but prior to that I spent many years working inside the British political process and inside a large government agency. So over those years I was on the receiving end of the kind of advocacy programmes we're talking about today, by non-governmental organisations. So in a way, I see it from both sides. Many of you will have seen the MSIF advocacy process. There is a toolkit which we'll talk about later, a webinar that we previously did on this issue, and that set out different phases of the advocacy process, which I will use to structure my comments today. There was a few things I wanted to emphasise at the outset, though. One is theory of change. If you're using theory of change, this neat circular approach doesn't work quite so well. You will inevitably have to go back sometimes to change things, change your thinking on the issues as you go through building your theory of change. I would recommend that you do that. Linked to that is the idea of adaptation. So, of course, you should evaluate and adapt at the end of any programme of work. But particularly for advocacy, you need to be adapting as you're going along. Don't just wait till the end if things aren't working or if there are new opportunities. That's really important to be opportunistic as well as carefully planned. And I would stress relationships at the outset too. Relationships will be important in terms of your need to adapt. If you do it well, you'll be reflecting on what others are bringing into the work you're doing, which might mean that you change your objectives or your analysis, your plans. So be flexible and really take the relationship seriously, but I'll come back to that. Be clear about your issue. So access to DMTs is complicated, access to medicine generally is complicated, and the issues which are paramount in one country aren't quite the same as the others. So be really clear about what your issue is. And some of the things I've listed here have been given to MSIF in the past. We had a meeting in Rome, for example, where members talked about what their challenges were. So it might be that you have no DMTs available, or that you have maybe one or two of the really old DMTs available, but none of the newer treatments, none of the higher efficacy treatments, or there may be some other barrier in the prescribing process. In many countries, it's just too late in the disease course and they need early treatment as well as a wider range of treatments. In some cases, there's no reimbursement or inadequate reimbursement, or MS treatments are not even covered by insurance schemes that work in the country. In some cases, it's inconsistency of supply. We have numerous examples that medicines are notionally available. People can notionally access them, but supply of the medication is so inconsistent that that becomes a real problem, especially for a disease where maintenance of therapy is important. And then there may be a whole range of support services which are a challenge too. It might be pre-screening, it might be monitoring of treatment, monitoring of disease. So there's all sorts of issues. And even right at the really basic level, the problem might be about getting a diagnosis in the first place, or the diagnosis itself occurring too late in people's disease course. So be clear about what the issue is in your country, and it may be more than one of these, but try to have clarity in your thinking at the outset. A general rule is that the closer you get to changing public policy, the more scrutiny you're going to receive and your arguments will receive. That's not always the case. You might get lucky, but don't rely on being lucky. So you need to have a really credible case. You absolutely will need evidence. Evidence is crucial in all sorts of different ways. I mean, you need evidence that the problem exists. You need evidence of the scale of the problem, how many people are affected, for example, and don't be tempted to try and exaggerate the scale of the problem, because that can work both ways. So a bigger problem can attract more focus to your issue, but on the other hand, it can put decision makers off because the cost of achieving your solutions might be considered to be too expensive. So just try to be as fair and accurate as you can be as you assemble evidence. And I say credible because that's what really matters. It doesn't have to be peer-reviewed, journal published evidence. That's ideal, but other forms of credible evidence are fine too. So if you're doing things like surveys, try to do them to a high standard, which other people will see as being credible. You do really need to understand the issues. You need to show the decision makers that you understand them, because if you don't, all of your arguments, when you come under that closer scrutiny, will start to fall flat. So when I was talking about the range of complexity, show you understand that complexity in your setting, in your country. So is it a problem of screening? Is it some aspect of the clinical pathway? Is the real problem enough clinical time on the part of clinicians? All of those sorts of things. Be clear about what the barriers are. Be clear about what you want to achieve. If you can show comparisons to other countries, particularly regional, that's really helpful. It can really help to show that even in the context of your country, progress is possible. And really try to understand, this is a critical point, try to understand the perspectives of the people you're trying to influence. Not just how do they make their decisions, but what are they thinking, what's important to them, what really matters to them, because that should shape your arguments that you're using. There is the issue of, does your country have an essential medicines list? At our last count, 137 do, but that leaves a lot of countries that don't. So if you do, then the opportunity to influence access to medicine is in many ways more straightforward, it's simpler, the opportunity is more obvious. But if you don't, the opportunity is still there, and you'll see that in one of the case studies in New Zealand, that any change like this in the public policy world, which is the essential medicines list is part of, is an opportunity for you to revisit decisions that have been made in your country previously, or to make fresh decisions. So don't think that if you don't have an EML, that this isn't suitable for you. It is. Develop your objectives. A high-level goal is really good. So something like people with MS should have the choice to be treated with the right medicine at the right time, but try to be more specific, because that'll be useful in all of the planning work you're going to do. Something along the lines of people with MS should be offered high efficacy treatment within 4 months of diagnosis, or a range of treatments that includes high efficacy treatment within 4 months of diagnosis. And that's just an example. What works in your setting needs to be geared towards what's possible in your setting. But also be clear about the outcomes that you're going to need to achieve to make progress. So it's not just focused on your end goals, but what are the stepping stones that you're going to need to achieve along the way. You might, for example, need a new professional guideline on the treatment of MS nationally. It could be that you need the health authority to agree changes to their reimbursement policies, or insurance schemes to adapt to the treatment of MS. So that consider the outcome, the specific outcomes you're going to need to achieve, and how those fit together. And that, using the theory of change can really help. That's why I recommend it. This is an example from an organisation in the UK. Their resources are very, very good, but I would just caveat to say that they are in English. But there are many logic models or theory of change methods, but I would recommend that you use them. And some funding organisations even require organisations like ours to have gone through a process like this when they're seeking funds. I'm a big advocate, but I won't dwell on it today because it's a big topic. Stakeholder analysis is critically important. Who do you need to decide things? It might be a health minister, it could be a key government official. Jen set out earlier lots of detail about how the WHO makes its decisions, including the fact that they have an expert committee, and we knew at the outset the character of that committee and how they worked and who they are as people. So they were all leading clinicians within their countries. So understand the people you're trying to influence. Understand how they make those decisions. Jen took us through all of the depth and detail of how the WHO do it. At the most basic level, it is that expert committee. They review formal applications. They only do it every 2 years. They make recommendations based on all of those criteria, and then the WHO basically accepts them. So whatever the process is for the decision makers you're looking at, understand those processes, the timing and who's making the decisions and what they would need from you to influence the decisions they're going to make. So things like what evidence do they consider? Do they respond to public pressure? This is a really interesting dividing line in many ways. That on the one hand, organisations might get involved in loud, emotive, public relations style campaigning, but on the other side, it might be the quieter, what I call constructive engagement. Both are perfectly legitimate, but you really need to understand what you're trying to achieve and the contribution those make to the decisions you're trying to influence. You might be able to achieve your goals in access to medicine without loud, emotive campaigning. You almost certainly won't be able to achieve your objectives without constructive engagement. And so my presentation is biased here towards constructive engagement, but it's not to say that loud campaigning isn't useful. And your allies are crucial. I couldn't stress this too much. So health professionals, first and foremost, you really, really need them to be on your side, signed up to your objectives, to agree that's what you're asking for is both possible and desirable, all of those things. There may be other patient groups that you need on your side. There can be, as I've found in the past, officials within the system that are naturally sympathetic to what you're trying to achieve. So work with people like that. Don't just see them as people as targets of your influence, but they need to be partners and allies on your side. And the same is true of industry, that you need to be seen as independent of industry as patient organisations, but they're absolutely fundamentally important partners in the process too. So make sure that they're involved when it's appropriate. A bit more on building relationships. There may be people in the system that you have absolutely no contact with, but you may know people who do. So use your existing contacts. Some of the leading clinical professionals, for example, may know people in the government decision-making process. So you can influence using people you already know, even if you don't know the decision makers. I absolutely encourage you to have lots of meetings, talk to people, learn from them, adapt your work to the contribution they make to you. The question of whether you can win their support, not always is the truth, but you can often push people from being opponents into being at least neutral, if they're neutral into being supporters, and if they're supportive, you may be able to persuade them to be more active. So try to take people along the kind of ladder of engagement. And be a convener. Bring stakeholders together. We saw this in Egypt, where a patient organisation can bring together government officials, health professionals, industry, that can help people to hammer out a deal that works for everyone. So even if you won't necessarily have all of the means to do that, work with the people that can. Convince government, for example, to bring those people together to hammer out a deal, or work with professionals to use their influence to bring people together. But convening is really important. And as I've said, revisit the work you've done, learn from the others that you're working with, involve them in shaping your plans. This is particularly important for health professionals, but all of the others too. Really make them partners and not just targets of influence. Planning in a way is obvious. You need to plan quite thoroughly, but as I've said earlier, be willing to adapt as well as you're going. Many of this will be very familiar to you. You do need to develop your key messages for the different audiences, preferably involve many of your stakeholders in the development of those. Really think about how you can reach your different audiences, because it won't be the same way. I'd really say consider the timing of your activities. So if you've worked out, as we did for the WHO, that they make a decision every 2 years, gear your work towards the decisions that are being made when they're being made. And that can influence, for example, when you switch from loud public relations type campaigning to constructive engagement, for example. And what other hooks or opportunities are out there in terms of timing. So the fact that we even now have a WHO decision to include MS treatments is an opportunity. And so the timing is really important now for lots of the influence we want to see. But there will always be hooks. in your annual or multi-year planning around which you can build things, even if it's something that occurs regularly, like World MS Day. Think about when is a good time. And similarly, who needs to be involved at the different times. And importantly, don't assume that they're ready to do things whenever you want them to be ready to do things. Try to give people plenty of notice so that they can be full partners in what you're doing. I won't say too much about implementation. It is the point really about adapting and taking advantage of new opportunities. I have seen people in the past say, oh no, we can't take advantage of that opportunity because it wasn't in our plan. And it might require you to reconfigure some resources to do it, but missing opportunities is generally a bad idea. And remember to keep partners on board throughout. So even if, for example, let's say you have a key meeting with government ministers, you may not be able to bring all your partners to that meeting, but keep your partners informed, certainly afterwards, preferably before as well. Evaluation does matter. Some funders will require at the outset that you know how you're going to evaluate your work, even before they agree to fund you. How will you know whether you're being successful? How will you know whether you should be adapting if you have no kind of evaluative process? And I would encourage you to think in qualitative as well as quantitative terms. So quantitatively, you might have things like what proportion of people with MS are being treated with the DMTs or with a particular category of DMTs. How many people are being treated with each DMT would be great to know if you know that. But qualitatively, look at whether the outcomes you know you need to achieve are being achieved. And that's not always a completely clear-cut issue. Sometimes you're partially achieving them, but it's important to reflect on through the process. And it could even be things like how well do people with MS understand their treatment options? So there can be that kind of qualitative and possibly quantitative evaluation tool you use as well. And then other tools and guidance. Abdul will cover MSIF toolkits that are available. I would encourage you to learn from other MS societies around the world. There are some great examples of their work, and many of those produce terrific resources that you can use. But really be inspired what you see others do, learn from people. It doesn't have to be only in the sphere of MS. So if you see other patient organisations or other campaigning organisations doing things that clearly are influencing public policy and practice, learn from them. Don't be afraid to some way copy what other people are doing. And in that spirit, I always point people to the tools provided by Plan International. Not a healthcare organisation, it's a global educational organisation, but they do have some terrific resources specifically on advocacy, and they're available in English, French and Spanish, which is helpful. So that's it from me.
We're running slightly late, but we will be staying a bit extra for questions and answers. So do feel free to post those in the chat. Whilst we're waiting for you to post any extra questions, we can cover some of the questions that we got during registration. And the first one was around pharmaceutical industry reactions to the listing of MS-DMTs onto the essential medicine list. Nick, maybe you would like to start on that one.
Sure. So some companies actually made written comments to the WHO during the process, but MSIF has also been talking to companies since we made the application and of course since the result was known. It's been a mixed reaction. Overall, I would say positive that we made an application, positive that we got a positive result. Certainly welcoming the bigger picture, if you like, that the WHO has given this stamp of MS being a priority disease that needs to be treated. So that side of it, very happy with. Inevitably, one or two companies would have liked their product to have been one that was listed. And I would say there is, people are a bit unsettled about the listing of an off-label therapy. That's more contentious to most of the pharmaceutical companies, but obviously one in particular. But overall, quite positive. And I think in one or two cases, They would have liked to have been involved throughout the process, whereas other companies understood why they couldn't be. But I would say universally, the companies want to be involved with MSIF, and that would also apply in most national contexts. They want to work with patient organisations as we go forward and look at implementing plans to make medicines more widely available.
Thank you very much, Nick. And I can see that there is a question in the chat, which is, many MS organizations have not advocated for access to treatment before. Where should they start?
Is that for me first? Gosh, I would say it's try to go through the process, really try to understand what the issues really are in your country. What is the pattern of treatment? What are the gaps? Because they're not the same from country to country. So really try to understand the problem, and then as soon as possible, try to engage other expert voices, in particular health professionals, as early as you can. And try to form that as the kind of core partnership. And then over time, you should be able to incorporate other voices, such as industry or government officials. There's a range of people you may be able to bring on board, but right at the outset, really try to understand the issue, work with health professionals to clarify some of those issues. And one of the things they can often bring is kind of the body of evidence that you might need, or at least help you to step up the evidence you have that your issue is real and needs to be addressed.
Thanks, Nick. And maybe I can ask Jen, sorry to put you on the spot, but I know that MS Canada does a lot of advocacy as well. Would you like to comment on that one as well?
Sure. We, in addition to what Nick suggested in consulting with clinicians and other specialists in the area, in the field, we would also, we have a lot of engagement from the community. So we would often get the voice of people living with MS, how it's impacting their quality of life day to day. So we would include all of this in any kind of application for to have a new drug listed. And we have run into some issues here in Canada. If anybody would like to reach out, we are more than happy to share any of our material or learnings, because often we also feel like we're starting at zero as well.
Thanks, Jen. And next question is for Shanti. What is the link between national treatment guidelines and a national essential medicine list?
Yeah, thanks for that. So the National Essential Medicine List is basically a list of basic medicines that a national healthcare system should have so that they can provide or satisfy the needs of that particular population. So that National Essential Medicine List is inclusive of all the subspecialties, and it includes neurology-specific drugs. So the National Treatment Guidelines is disease-specific. It's basically for a particular disease, how you would use those drugs based on the current best available evidence. So these two are very different. But what happens with the National Treatment Guideline is that it can help in terms of how you would use the drugs that are already listed on the National EML and vice versa. Thanks.
Thank you, Shanti. And there's a question regarding a situation where the country doesn't have a national essential medicine list. How is this relevant? I know we discussed that a little bit, but I was wondering if Nick and Amanda, you might be commenting on that a little bit more. So outside of the context of the essential medicine list in country.
Yeah. Well, most countries, even if they don't have an essential medicine list as such, most countries will have some sort of national formulary or process by which they appraise medicines. So is still there, and you'd use all of the same techniques that you'd use, because even if you have an essential medicine list, the influencing still needs to be done. There's rarely an automatic process by which a country will just list what the WHO has in their model list. They'll usually go through a process whereby they assess it, they make changes to their list, and they will need that to be, or you will need that to be influenced. So the techniques are very similar, and even if that list doesn't exist, as Amanda and Shanti talked through, there will be processes that you can influence to help shape those formularies and which medicines are available.
I agree, and you know, just being really clear around what are the drivers for with your you know, who you're advocating for, what is it that drives them in making those funding decisions as well. You know, here in New Zealand, it's very much an evidence base, but also we know that to get it through, we need to have the support of clinicians as well. So, you know, making sure that we have as many people on board, you know, having the patients, having the clinicians, and any other stakeholders that we need, and having that good evidence base behind us.
Thank you very much, Amanda. And I think the last question, I'm going to combine a few that has come up, is really about how to get started. And I'm going to hand over to Abdul. Maybe you could talk a little bit about the resources that we have available online. You're
Hi,
on mute.
everyone. Okay, thank you. Hi, everyone. Obviously, because of this time, I'm happy to follow up with a record, as I said earlier. What we've tried to do, I'll share my screen because easier. So we've established created a new section about access to healthcare at the website, as you can see. And the way we've kind of tried to do that is more like we take into consideration the journey of the visitors as they come through to this section. So you will have some information about improving access to treatment. Same for MS, improving diagnosis. There's much more in obviously access to MS treatment as we have worked in this area over the past few years. And within that will be some information about why why there is a need to advocate for improved access to treatment, and kind of the story behind the need for improved access to treatment. There is different section here. There's one section about learn from others, so very much like what we've heard today, but from other case studies, and this is where you can see how organizations use different techniques to advocate and improve access to treatment, from Australia to USA to Canada and many others. And actually, if you have a study a case study to share with us, please feel free to reach out to us. We'll be more than happy to add it to this section. And this is an ongoing, so we will keep populating this a little bit more. I would, if you are interested in embarking into advocacy, or even reviewing your advocacy approach to improve access to treatment and healthcare generally, I think this is a very good starting point. This is where we sort of, starting from basics, what's advocacy and how can you get started with advocacy. There's also some explanation of videos, but there's also some tools it's not created by us, it's created by other organizations, civil society sector, but they can be very useful and very much applicable on any cause or issue issue that you're trying to address. So these are available here. They're very detailed, step by step, and I think they can be very useful to look at and get inspired. In a nutshell, the key components very much on advocating for advocacy or advocating for MS is about, as Nick was saying earlier, is about the evidence and how can you collect that, and that takes you to Atlas of MS if you don't have evidence or information available in your country, and there's even a whole section about how to get the evidence and a way you can get started. Also, voices of people with MS is very important, and it got to be a center of everything that you do as advocacy. And here we're talking about what the storytelling can bring and how it complements evidence, and some example of stories that you feel free, any of our members can make use of them if they found them useful or relevant, or again, look at them and get an idea what we mean by story that very much focus on access challenges and how people with MS trying to navigate their accessing MS healthcare. and again, that take you back to learn from others. I don't want to speak more about this. I'll be recording a video in much more details and send it across. But please do have a look at this, familiarize yourself. If you have a feedback, please do provide us. If you have resources, tools, or your experience as a case study or a project that you've run in the past that you'd like to share with us, we'd be more than happy to have it, to look at it and hopefully add it to this section. Thank you.
Brilliant. Thank you so much, Abdul. I think that concludes our session very nicely and neatly. We will be sharing slides as well as recordings after the session. And Abdul has promised to make a specific video around the website and how to use that as well. So that will be circulated afterwards. We're also very happy to have one-to-one chats with any country if you wanted to discuss in detail your situation and how we can try and support you in also with using a lot of the tools that are available on our website. So with that, I would like to conclude. Thank you so much for all the speakers. I really appreciate, Amanda, I think it's midnight there, or is it maybe 1 a.m. already? So really appreciate that. And Jen, I know you had to get up very early as well. So we're very grateful for you for joining us. Thank you, everyone who attended.